I am Molly Feely. I am a consultant in palliative medicine here at Mayo Clinic in Rochester. And today we are talking about the management of opioid side effects. I have no financial disclosures, but we are going to talk about off-label use of methylnaltrexone, ondansetron, naloxone, modafinil, and methylphenidate today. So I want to acknowledge before we start that there are a lot of reported side effects from opioid medications, and today we're really only going to be talking about 5. Opioid-induced constipation, opioid-induced nausea, opioid-induced sedation, pruritus from opioids, and hypogonadism. The objectives today are to really distinguish when to rotate to a different opioid and when to treat through this side effect symptom. And in order to do that, you have to recognize which side effects are transient and are going to go away, and which side effects are more pervasive. Also, I hope you'll be able to list management options for each opioid side effect discussed today. And the way we're going to do that is we're going to start with a case, because that's how I remember things best. We'll talk about the principles related to that opioid-related side effect. We'll give some tips on management and some take-home points for each side effect. So we're going to start with constipation. And I saw this patient probably 4 or 5 years ago. She's a 37-year-old woman who has widely metastatic breast cancer. She was miserable when she came in the office. She hadn't had a BM in almost 8 days, and she was so miserable she actually stopped all of her opioid pain medications. And that was pretty impressive because she was on a 75 microgram fentanyl patch, and on top of that was taking hydromorphone 4 to 6 times a day. Her bowel regimen at the time that she presented to me was Docusate 100 milligrams BID PRN, milk of magnesia, 30 cc's TID PRN, and Miralax daily PRN. So in addition to giving her a successful enema in the office, which of the following would be the next best step in managing her opioid-induced constipation? Adding sorbitol, 30 cc's PRN, increasing her Docusate to 200 milligrams BID, adding a scheduled stimulant laxative, or adding methylnaltrexone. And the correct answer here is adding a scheduled stimulant laxative. So what do you need to know about opioid-induced constipation? Opioid-induced constipation is virtually universal in people who are on scheduled opioids, and it doesn't get better with time. Patients do not develop tolerance to the constipation. In fact, every time you go up on the opioid dose, the constipation gets worse. So you really need to aggressively treat the constipation. The backbone of treating opioid-induced constipation is scheduled stimulant laxatives. In fact, we have a saying: the hand that writes the opioid prescription writes the Senna prescription. So this is how I generally start and what I generally do. I generally start with Senna 1 tablet BID. If that doesn't work, I'll go up to 2 tablets BID. If that doesn't work, I'll go up to 3 tablets BID, or even up to 4 tablets BID. If 4 tablets BID of Senna is not adequate to manage the constipation, that's when I add a second agent. The second agent you choose is really up to you. It could be sorbitol, it could be Miralax, it could be bisacodyl, it could be lactulose. But add the second agent and then increase that to its max dose before you add a third agent. So you'll notice nowhere in the regimen I just described is fiber. Now, I don't want to badmouth fiber. Fiber is great. We all should have fiber. We all probably need more fiber in our diets. But fiber is not really very helpful in the setting of opioid-induced constipation. One of my colleagues famously said, opioids turn your bowels to concrete. Adding fiber just adds fibrous concrete. So don't add fiber. And if you're still using Docusate, Docusate is worthless. There are very good head-to-head, double-blind, placebo-controlled trials that show no benefit of DocuState over placebo. So you're wasting your patient's money. It's time to get rid of DocuState from the armamentarium. And if you've maxed out 3 laxatives and they're still struggling with constipation, that is the time to consider a peripherally acting mu-opioid receptor antagonist. So what is a peripherally acting mu-opioid receptor antagonist? These are drugs that block the mu-opioid receptors in the periphery, but do not cross the blood-brain barriers, so they don't block the mu-opioid receptors in the CNS. What that means is they block the mu-opioid receptors in the bowel, inducing laxation, but they don't block the mu receptors in the CNS, so they don't impact pain control from opioids. And they're really effective. I usually give a dose, and if there hasn't been an adequate response to the first dose, I'll repeat it the next day. If there's no response to 2 doses of a peripherally acting mu-opioid receptor antagonist, I start to question if I have the right diagnosis. That's how effective these are for opioid-induced constipation. Bowel obstruction is an absolute contraindication. There have been case reports of perforated bowel when these are used in the setting of bowel obstruction. So as you can see from this slide, this is kind of a comparison of the peripherally acting mu-opioid receptors that are currently on the market. And here is how I think about these. Subcutaneous methyl naltrexone is the first peripherally acting mu-opioid receptor antagonist that came on the market, and it is still the only one that is FDA approved in cancer or in patients receiving palliative care, seriously ill patients with life-limiting illnesses. There are now 3 oral peripherally acting mu-opioid receptor antagonists on the market: oral methyl naltrexone, naloxegol, and naldemidine. So how do you decide which of these medications to use? So my first question is, do they have advanced illness or not? If the answer is yes, I prefer to use sub-Q methyl naltrexone. If the answer is no, they have non-cancer related pain, then my next question is, do they have polypharmacy? Naloxegol and naldemidine are both substrates for the CYP3A4 pathway through the liver, and they interact with multiple different medications. So if the patient has polypharmacy and would be at risk for drug interactions, then I would prefer to use oral methyl naltrexone because it is not metabolized through that pathway. If they don't have polypharmacy, then you could choose naloxegol or naldemidine. Both of these agents are much less expensive than the methyl naltrexone agents. I prefer naldemidine because in head-to-head studies, it was more efficacious than naloxegol, with an odds ratio for laxation of almost 6 compared to naloxegol's odds ratio for laxation of only 1.5. And so if I have an option, that's what I would choose. In reality, in all honesty, most of the time you're picking a peripheral acting mu-opioid receptor antagonist based on the patient's insurance and what their insurance will cover. Take-home points for opioid-induced constipation is virtually universal with opioids. Tolerance does not develop and it does not go away with time. Start scheduled laxatives with scheduled opioids. Max out 1 medication before adding a second medication. Fiber is a no-no in this scenario. And consider a peripherally acting mu-opioid receptor antagonist if you've maxed out a bowel regimen. Okay, next, let's talk about nausea. So this patient is a 18-year-old woman who has severe destructive lupus arthritis. She has severe pain that limits both her mobility and her ability to do her own ADLs. And she has multi-organ dysfunction from her lupus. She has a limited life expectancy that I would estimate as probably less than a year, maybe less than 2 years. You elect to start her on hydromorphone 2 milligrams Q4 hours PRN for her pain. And within 24 hours, she is miserable with nausea and vomiting and tells you she cannot take this medication. Alternative etiologies of the nausea have been ruled out. What is the next best step to manage her opioid-induced nausea? Rotate her to fentanyl, switch her to IV hydromorphone, add scheduled prochlorperazine, add PRN ondansetron. So the answer here is add scheduled prochlorperazine. Now let's talk about why. Opioid-induced nausea is not uncommon. Depending on the study that you look at, it ranges anywhere from 15% to 40% of patients will get opioid-induced nausea. There are multiple potential mechanisms for the nausea. Rarely, opioids can actually impact the cochlea of the ear and give you a vestibular nausea. Certainly, if you have constipation and inertia in the gut, that can give you nausea. But by far the most common source of nausea is through the chemoreceptor trigger zone. The thing you need to know about opioid-induced nausea is over 90% of patients, this will resolve in 3 to 7 days as they develop tolerance to the nausea. And so in almost everybody, if you wait enough time, this will go away. That's really important because if you switch opioids on day 2 because of opioid-induced nausea, all you've done is reset the time to time 0 to start all over again. So this is one where you really want to try and treat through the nausea for 5 to 7 days before you switch drugs. And the factoid that you simply need to know about managing opioid-induced nausea is that it is mediated by dopamine. So the antidopaminergic antiemetics are the preferred agents to manage opioid-induced nausea, such as the prochlorperazine in our example. There is little evidence to support one opioid inducing less nausea than another. When you look at large populations, they all induce nausea to an equal degree. The one exception to that may be tapentadol, which is the new fancy cousin to tramadol. And tapentadol might actually have less GI side effects associated with it. So take-home points on opioid-induced nausea and vomiting. Avoid opioid rotation for the first 5 to 7 days if possible. Use an antidopaminergic agent first line to treat opioid-induced nausea and vomiting, and I prefer to schedule that for 5 to 7 days if patients are struggling with nausea, and then discontinue it and see how they do. This next patient is one of my favorite patients of all time. He was a longtime patient of mine. He's a 50-year-old man who is actually in complete remission from non-Hodgkin's lymphoma. Unfortunately, as a result of his treatment for his lymphoma, he was left with a pretty severe peripheral neuropathy that was quite painful. I tried to treat him with many neuropathic agents. I gave him gabapentin, and he developed edema from the gabapentin. I switched him to pregabalin, and he developed edema with the pregabalin. I tried to treat through the edema from the pregabalin with Lasix and compression garments. I'm here to tell you that doesn't work. I switched him to carbamazepine and successfully drove his sodium down to 108, which was my personal record at the time. I put him on topiramate. Have any of you seen the cognitive dysfunction that comes with topiramate? He got it. I put him on lamotrigine. Have you seen the rash from lamotrigine? He got that too. It's a really impressive rash. I put him on duloxetine, and he got suicidal. And I put him on a tricyclic antidepressant, and I literally had to shock the guy out of VTAC. All of these agents failed him. And so I put him on opioids for his pain. And the opioids worked for the pain. The problem is every single opioid we tried made him sleepy, including methadone. They all made him sleepy. He had been a longtime patient of mine. He had no aberrant opioid behavior. And the sleepiness that he was having was really starting to interfere with his employment. And he was starting to get negative reviews at work, and his boss, who had just been a trooper through all of his cancer treatment, was really starting to get frustrated with him because of his sleepiness and his difficulty he was having at work. The current medication he was on was a fentanyl patch. So what is the next best step to help with this patient's opioid-induced somnolence? Add modafinil. Tell him he can't be on opioids anymore because he doesn't have cancer pain. Tell him he should quit his job and go on disability. Or start an SSRI. So the correct answer here is add modafinil. I will tell you, he was told every one of those options. He was told he couldn't be on opioids because he didn't have cancer. He was told he should quit his job. And he was told he must be depressed and he should start an SSRI. Now, I am a general internist by training, and I absolutely hate treating a side effect of one medicine with another medicine. But rarely it's the right thing to do. Opioid-related sedation is not super common, it's not rare, but it's almost always transient and it almost always goes away in 2 to 3 days. And so the question when I see persistent somnolence that seems to be related to opioids is what else is going on? Am I missing sleep apnea? Am I missing depression? Is there another drug that is exacerbating somnolence, benzodiazepines being the prominent one? And if I can't find anything else going on, my third question is, really, what else is going on? I really look hard for other etiologies because it is so uncommon for the somnolence to be persistent. If the somnolence is persistent and I can't find anything else going on, then I really try to do a different drug. Is there a different opioid they can be on? Is there a non-opioid medication they can be on instead? I think we can all agree that this guy had legitimately tried everything else out there and nothing had worked so far. And so in the end, as a last resort, you can consider a stimulant medication to help with the opioid-induced somnolence. And as you can see from this slide, there are a couple of stimulants that we sometimes use for this, methylphenidate and modafinil, and they have a similar side effect profile. They can worsen anxiety. They can cause a little bit of tremulousness, like you've drank in a pot of coffee. They can cause cardiac dysrhythmia, although most commonly it's atrial dysrhythmia, atrial fibrillation, or supraventricular tachycardia. And if you give it too late in the day, it will cause insomnia. And so you want to make sure that you give the last dose no later than 2 p.m. I usually tell people 8 a.m. and noon. And they supposedly can cause anorexia. And I'll be honest, I have not seen that be a significant issue clinically, even in my palliative care populations. The doses are as noted on the slide, and then the only thing I would reiterate is don't give the second dose after 2 p.m. So opioid-induced sedation take-home points, it's usually transient, wait several days. What else is going on? And stimulants really are a last resort for this, not first line. So let's talk about opioid-induced pruritus. So this is a young man who I admitted one night with a tib-fib fracture. He was 24 years old, and I think he had been hit by a car, and he had a tib-fib fracture. He was going to the OR in the morning. And he reported allergies to morphine, codeine, oxycodone, and hydrocodone. Now, the obvious question is, why does a healthy 24-year-old have been exposed to morphine, codeine, oxycodone, and hydrocodone in their short lifetime? And that probably would have been a really good question for me to ask this young man. I don't think I ever asked him that, but he complained of pain, and non-opioid medications were not adequately controlling his pain. And so I ordered him hydromorphone for his pain, and he almost immediately started itching. The exam showed no rash. So how would you manage his opioid-induced itching? Switch him to IV hydromorphone, add PRN diphenhydramine, schedule loratadine, which is Claritin, switch him to nalbuphine, which is Nubain. So believe it or not, the correct answer in this setting is switch him to nalbuphine or Nubain, which is what I did to manage his itching. Opioid-induced pruritus is not an allergy. You can get allergies to opioids, but it usually presents as anaphylaxis. Opioid-induced itching causes really intense, uncomfortable itching with no rash. It is more common in axial opioids, so spinal, epidural, or intrathecal pumps is much more common than systemic, but you can get it from systemic opioids. And this is the most important thing, it is not a histamine-related phenomenon. While it is true that opioids can sometimes induce mast cell degeneration, that is not the etiology of the itching. So please, please, please stop snowing these people with Benadryl. It isn't helping their itching. And loratadine doesn't help their itching either. We don't actually know what the mechanism that causes opioid-induced itching. It is speculated that it's actually an opioid receptor phenomenon, possibly a kappa receptor phenomenon. In terms of managing opioid-induced itching, there is almost no data outside intrathecal opioids and the management of opioid-induced pruritus related to intrathecal pumps. And so the management of systemic opioid-induced pruritus is largely based on expert opinion and extrapolation from the studies done in intrathecal opioids. So this chart that you see in front of you is how I think about managing opioid-induced pruritus. For reasons we don't entirely understand, there are some drugs that simply have less pruritus associated with them than others. That would include hydromorphone, fentanyl, oxymorphone, and tramadol. We don't know why they have less opioids, but if possible, switch them to one of these opioids as a first-line attempt. Naloxone works great for reducing the opioid-induced itching. The problem with naloxone is it also reverses the pain control, so it's not a very practical option to treat opioid-induced pruritus. Opioid agonist-antagonist drugs such as nalbuphine and butorphanol is Stadol, have by far the best evidence in the management of opioid-induced pruritus. Most of these studies and most of this evidence is in patients with intrathecal pumps, where the intrathecal pump is actually managing their pain, and they will take PRN doses of nasal butorphanol to manage the itching. In a patient like mine who had pruritus from systemic opioids, I did successfully use Nubain to manage his pain perioperatively. And once he had surgery, his pain was much better controlled and could be managed with an NSAID. Now, it was a very interesting conversation with the pharmacist in the middle of the night about why I was ordering Nubain for a 24-year-old young man. Because normally Nubain is used in labor and delivery. But I did eventually get it, and it was successful for him. He had very little itching on it. One of the newer opioid agonist-antagonists on the market is buprenorphine. It has not been studied in opioid-induced itching, so I cannot tell you whether it works or not. It is an opioid agonist-antagonist. And if you have somebody who has a more long-term opioid need or an outpatient opioid need, buprenorphine in the form of a Butrans patch might be something to consider trying. If opioid-induced pruritus is an opioid receptor issue, then methyl naltrexone might be something to be considered because it blocks the opioid receptors in the periphery, but does not block the opioid receptors in the CNS, therefore maintaining their pain management. There is a small double-blind placebo-controlled, well-done study of 72 patients looking at methyl naltrexone for opioid-induced itching, and in fact, it was no better than placebo, so that didn't really pan out. There are several case series showing benefit to ondansetron and mirtazapine for the management of opioid-induced itching. We do not know why they seem to work. The studies are conflicting, but I have successfully used ondansetron in the past to try to manage opioid-induced itching, and that is an option to consider with few side effects. So take-home points for opioid-induced pruritus. It is not a histamine phenomenon. Stop throwing antihistamines at it. Consider an agonist-antagonist opioid, and consider ondansetron or mirtazapine as options. So my next patient is a 47-year-old man who has severe peripheral neuropathy secondary to a treated amyloidosis. He currently has stable disease status post a stem cell transplant, and unfortunately, he did not have any improvement in his severe peripheral neuropathy with transplant. His medications are a high-dose fentanyl patch, 100 micrograms every 3 days, oxycodone, 20 milligrams every 4 hours as needed, max dose pregabalin, 300 milligrams BID, and max dose duloxetine, 60 milligrams BID. He has gained 40 pounds in the last 6 months. He has increasing mood disturbance with depression and anxiety. He is fatigued and not sleeping well. And his pain continues unabated and, if anything, is worsening. And at his office visit, he asks about adding medical marijuana to his regimen to help with his pain. Which of the following is the next best step? Prescribe him medical marijuana, check a morning testosterone level, switch his duloxetine to venlafaxine, add methylphenidate to help the fatigue and augment his antidepressant therapy. And the correct answer here is check a morning testosterone level. So opioid-induced hypogonadism. This is surprisingly common. Within 30 days of starting scheduled opioids, somewhere between 20 and 80% of people will have evidence of hypogonadism. And the hard part about opioid-induced hypogonadism is it is a huge masquerader. You know, in the early part of the 20th century, syphilis was the great masquerader because it looked like a bunch of different things. In the 80s and 90s, HIV became the great masquerader that looked like many different things. Hypogonadism really almost always looks like something else. And you really have to be very vigilant to think about this as that might be going on. Think about this as in your differential diagnosis. And you have to ask the right questions because this always looks like sleep apnea, or it always looks like depression, or it always looks like something else. Opioid-induced hypogonadism occurs in both men and women, but there are almost no studies in women. And when it's identified in women, it is almost always identified in premenopausal women in whom it impacts their menstrual cycle. What this looks like, what opioid-induced hypogonadism looks like in postmenopausal women, we don't know. It's most studied in men, and so I'm going to focus on men for the moment. And it causes lots of different symptoms. It can cause fatigue. It can cause cardiovascular symptoms, stroke, heart attack. It has reduced muscle mass and increased body fat. It induces osteoporosis. It can give people depression, mood swings, mood lability, decreased concentration, and failing memory can be signs and symptoms of opioid-induced hypogonadism. It can cause alopecia and hair loss, and it can cause sexual dysfunction. And the hair loss and the sexual dysfunction are the ones I tend to focus on. And so my questions that I tend to ask when I'm thinking about this is, does a man have to shave less frequently than he used to? If a man's used to shaving every day and he suddenly only has to shave every third or fourth day, that could be from hypogonadism. And I also ask about sexual functioning and typically about morning erections and a change in morning erections as my screening questions for might this be hypogonadism. Hypogonadism is a clinical diagnosis. You need to have the clinical signs and symptoms first, and then it is confirmed with laboratory findings. And the laboratory that you want to do is 2 total testosterone levels that are done before 10 a.m. So you do the first one, is it low? And then if it's low, you want to confirm it with a second test. If the patient has borderline levels, you could consider doing a bioavailable testosterone, but for the most part, your screening for hypogonadism should be a total testosterone level before 10 in the morning. And I'll be honest, if this is abnormal, I tend to send them to the endocrinologist to complete the eval. I don't personally order LSH or FSH or prolactin or ferritin or transferrin or all of the other labs for workup. And I don't do an extensive evaluation for confounders or causes, I send them to the endocrinologist for that. As you can see in this slide, treatment for opioid-induced hypogonadism works, but it's complicated. Patients who have opioid-induced hypogonadism, who are treated with testosterone, have improved quality of life. They actually have less pain. They have improved osteoporosis and improved moods. The challenging is the risks of testosterone replacement are confusing. Does it help cardiovascular risk or does it worsen cardiovascular risk? Does it decrease the rate of prostate cancer or does it increase the rate of prostate cancer? Does it cause OSA or does it treat OSA? And it's very confusing. And since I am not enthused about staying up on all of those things, I tend to ask my endocrinologist colleagues for help once I've actually made the diagnosis. So take-home points for opioid-induced hypogonadism. It is common with negative health consequences. It does resolve once they're off opioids. It is a great masquerader. You have to think about this. This diagnosis is not going to jump up and bite you. You have to think about it and you have to ask the right questions. Treatment helps, but treatment is complicated, and don't be shy for asking for help. That's all I have for today. Thanks so much for joining me. I've really enjoyed it. Here is my email address. Happy to take questions.